Hello, everyone, and welcome back to the world's okayest physical therapist podcast. This is your host, Dr. H. And today I'm being joined by a fellow doctor, though one would argue a real doctor, a doctor of osteopathic medicine, which I will let him introduce himself now. How are you doing, sir?
Doing good. I'm Dr. L. Currently finishing out my emergency medicine residency. And I went to osteopathic medical school for 4 years prior to residency. So yeah, happy to be here.
So for just people, as they have an idea, so what's the difference between doing the schooling and doing residency, just so they understand your time commitment?
Absolutely. No, that's a great question because, to be honest, I don't even know if I knew that when I started medicine. Becoming a doctor in the U.S., I'll just kind of give a brief overview. But if you want to become a physician in the United States, your options are to do what's most people don't know, but allopathic or osteopathic medical schools, and that's the MD or DO. Both get you to the same place. They're slightly different in that osteopathic, I guess they're becoming more and more similar. So osteopathic used to be very different. It was more in the frame of physical therapy plus chiropractor plus medicine. And now it also focused on kind of like your holistic care, preventative medicine, and kind of like the mind, body, spirit connection. But I think MDs are taking a lot of the kind of good stuff that started the osteopathic profession to begin with, because they've kind of seen the usefulness of those, focusing on those attributes. So I feel like there's become less and less difference over the years. In 2020, they just combined residencies, or what was called the residency merger. There used to be osteopathic specific residencies. Like there used to be residencies in emergency medicine, like what I do, internal medicine, neurosurgery, that were only DO, and DOs only would apply and then get in. And then there were only MD residencies where only MDs would apply and get in after they finished medical school, of course. And now those two things DOs and MDs can apply to whoever's residency. There's no difference. So after you complete 4 years of medical school, either DO or MD, and medical school consists of typically 2 years of academic study, where you're just studying, taking board exams, taking lots and lots of tests. And then after those 2 years, you do the last 2 years of medical school, which are clinicals. Right. So those you have, your third year is generally a structured set of clinicals that you have. They're typically cover your basic practices like family medicine, internal medicine, surgery rotation. Some schools have emergency medicine, psychology or psychiatry, excuse me. And trying to think of anything else that they would have to cover. Those are the main ones. Every school is a little bit different, but they all have those basics. And then your fourth year is more clinicals, but this time you get to choose. So that it's kind of an elective year. So after, a lot of people know, you see a lot of people, the common thing is your pre-med that's decided he was a surgeon since he was 5 years old. He already knows what he's going to do. But for a lot of people, they kind of figure that out third year, because you have to do a surgery. You have to do an internal medicine rotation. So you're kind of getting that experience. And then by fourth year, hopefully you have a good idea and you can start choosing those specifically. And then you kind of know the end of your fourth year, you get your application ready for residency. And so you apply to residency programs, which are different from medical school, because after you finish medical school, you become a doctor. So in residency, you're a physician, you're a doctor. If you finish your first year, you're licensed, and you, in theory, can practice on your own. But to be a specific type of doctor, like if you want to be a surgeon, or if you want to be an emergency medicine doctor, then you have to finish an emergency medicine residency. If you don't, like in the old days, it was much more common. You can do it now. It's usually fewer and far between. You typically, can find a lot more jobs if you have a residency and board certification. But if you want to finish an intern year, just 1 year of residency, you can get your medical license after your intern year and then practice on your own. You can open up your own clinic or whatever you'd like to do. Um, and yeah, that residency is essentially just like on the job training where you're a doctor, you do get paid, albeit a paltry salary compared to the actual, physician. I think in the ER, and obviously it fluctuates. We get paid probably an eighth of a salary or normal salary. So, and I can get into that too. I don't know how much you want to go into the craziness of that residency is. And it's like it's kind of an abused system right now where um, they hospital systems get paid by the government to have residents, and so it's basically free labor for hospitals. So it kind of behooves every hospital system to have a residency program because you're kind of getting, especially by the time you get towards the end of residency, like there's not a lot that will differentiate like a third year ER resident that's 6 months from graduation and a new attending,
Mm.
it's not that much of a difference, but one of them you can pay like one eighth the salary. So it's nice for hospital systems to kind of uh, get that, but
So
sorry.
could one argue perhaps then that the system's almost incentivized to burn out those students?
Oh yeah, and man, don't get me started on residencies. So the residency now, you might have to look it up. Let me see if I can find it. But I know there's the guy that created residencies in the first place. Um, he was a surgeon way back when, and not as well known. He was also a cocaine addict. Um, so he worked like insane hours. I think Dr. William Halstead, yeah, that's his name. So he pioneered, if you want to call it that, the modern residencies over at Johns Hopkins. And he was a surgeon. He worked like 80 hours a week, and so he expected his residents to do the same. And they didn't know that had a severe, one would argue, crippling cocaine addiction that allowed him to work 60 hours or 80 hours a week. So for a long time, residents, they're called residents because their residence is at the hospital. They're supposed to always be there.
Mhm.
So they followed this cocaine addicted surgeon's example for a long time. I think in the early 2000s, there was a case where a resident, I think it's called the Libby Zion case, where a resident was basically working like on a 36-hour shift, and they made a clinical error that cost the girl her life. I think she was either neuroleptic malignant syndrome or I think it was neuroleptic malignant syndrome, or maybe it was serotonin syndrome. But it was one of those kind of like, it was kind of like a rhabdo inducing myoclonic condition. And the patient, who was a young girl, died as a result.
Mm.
And so instead of suing just the hospital, the parents kind of had a lot of wisdom, noticed that, this error was made because of the way the system is.
Mhm.
If this young doctor hadn't been, on a 36-hour shift and was kind of borderline being abused, then he probably wouldn't have made the medication error that ultimately led to their daughter's death. So that changed residency laws. So now there's an 80-hour limit a week, and so which is kind of it's better. I guess it used to be worse than that. So that's nice. They're it's hopefully starting to move in a direction, and hopefully it'll keep going in that direction.
That's one of the things that I try to explain to people right in the beginning. If people have been listening to the podcast for any period of time, they're used to me saying labyrinthine and Byzantine American healthcare system, and I think I don't try to sugarcoat things, but I do try to remove any personal bias. So, like, for people to know that that's what residency was founded on, like, welcome to residency, brought to you by cocaine, um, or things like that. It's helpful for them to hear that because then when they see that doctor, when they see that healthcare professional walking into their room, they're like, "Oh, this could be someone that's being taken to task by the system. Like the reason why they have dark circles under their eyes isn't that they were out partying last night. It's the fact that they might be pulling a 24-hour shift or and I think that kind of ties into like the why this system is broken it ties into also what you said earlier about how DOs are more plugged into like the whole body, the whole human. It's not just one aspect. Y'all, I mean, whenever I get a referral from a DO, I usually get a referral from a DO saying, "Hey, by the way, I screened them. I'm pretty sure they got rotator cuff impingement with like a specific sort of maybe infraspinatus pathology going on." And I'm like, and then they list the special tests they do. I'm like, my man, you knew what you were doing versus when I get it from like an MD where it's like, I don't know, the patient says their shoulder hurt. I think this is shoulder impingement. And then they show up and they can't get their arm above 90 degrees. You're like, oh, you have like a at least partial tear of the rotator cuff, most likely. Who wrote shoulder impingement on here? But I think all of that you said kind of ties into the why the burnout happens. And I know I've harped on the physical therapy side of things, which notice I'm being awfully silent about physical therapy clinical rotations because 80 hours is nowhere near what we get close to. We are doing our 40 hours a week, sometimes more if it's like government setting. But 80 is just insane. And it's crazy that it takes, unfortunately, someone losing their life for that system to change. But I think it's important for people that are listening to know that because it's only when something goes drastically wrong that the system is interested in self-preservation. And that's what's going to make it change.
Right. Yeah. I think that's more or less it. I mean, I think a lot of doctors there here, I'll say this. There's two kinds of people in the world. The first kind is those that say, I suffered, so you must suffer also. And the
Mhm,
other kind that say, I suffered and I don't want you to have to go through the same thing.
mhm,
So I think there is hopefully a tide changing in that a lot of the new doctors, they recognize the importance of residency, but it's the way it is right now, and kind of how toxic a lot of residencies can be is not healthy for anyone. It's not good for patients. It's not good for training doctors. And so I hope there is a change, and I think in some sense we've seen a little bit over the last like decade or so.
mm. Let's steer from residency, which is brutal. One could also probably argue torturous. To more like let's talk about from the idea of okay, let's have someone who is now out of residency, has been practicing for a while. Let's talk about like the sort of things for maybe like the administrative burden that they're carrying. So even now that you're out of residency and you're now practicing and you're maybe a little bit more able to choose your hours and things. What
Mhm.
are some things though that you've seen either in your own personal experience or that you're familiar with that's like, oh, this still contributes to burnout amongst like either the DO, MD, or just general healthcare population that you're in the hospital setting?
Yeah, absolutely. So yeah, I think with burnout, so ER is has been cited in a lot of recent studies as the clear winner of burnout. There's a lot of studies that show it like 53 to 63% of ER physicians report uh, high symptoms of burnout, which is number one in all specialties. And no one was thinking dermatology was going to be there, but it turned out to be.
Dermatology's on there?
No, it's not.
Oh,
Dermatology's got to be the lowest. Um, they have great lives. So yes, I mean, there's a lot of things that can contribute to burnout for ER doctors. I mean, it's one of the few, and this is it's a little bit of just kind of my take on it. It's one of the few positions as a doctor where you're seeing life and death a lot. So I mean, and you can see it in kids sometimes. You can have connections with the patient, and then uh, that patient can die shortly thereafter or under your care, and that's not a foreign thing to happen. So it does take a toll. A lot of people like the ER because if there's a change, we can immediately see it, kind of like saving life. But
mm,
obviously you can't save everyone, and when you lose someone, that can hit hard. Um, Another thing, I mean, these are kind of like standardized things, but the fact that it's shift work and a lot of ER doctors have to change from days to overnights frequently and back to days in the same week.
mm,
So whether you're in residency or not, you can get scheduled to be, Monday, Tuesday, you're 7 a.m. to 4. And then the next day you've got like an overnight shift, and then you're back, Thursday or Friday, 7 to 4, or back to the day shift. So the constant change in schedules and fluctuation in your circadian rhythm kind of makes, I think it definitely adds to the burnout. Um, physician Physicians dealing with just like patient boarding, which for those that don't know, patient boarding is just when there's not enough room in the hospital and you have a patient that needs a hospital bed, but they're kind of staying over in the ER just because there's nowhere for them to go until that hospital bed's ready. A lot of hospitals, I mean, hospitals are businesses, so they operate in a way that says, how do we make the most money?
Mhm.
Kind of like an airline where they try to cram every seat, right? There's airlines don't benefit if this every seat isn't full. So a lot of times they'll overbook the plane and then they'll offer someone a ticket or offer them a $500 voucher to go if everybody shows up. They're assuming that everyone won't. In a similar way, hospitals they're kind of trying to get as much business as possible, and so they're trying to fill up every bed because in the hospital CEO's mind, if a bed's empty, that's costing them money, right? I mean, that's affecting shareholder value, and that's not good for them. So, in a lot of ways, it's how do we fill up as many beds as we can? But then when you do that, your result is you have plenty of patients that are a lot of times sick in your hospital, that are just sitting in the ER hallway. And for sick patients, like I mean, it's not uncommon in emergency rooms to have very sick patients that are in rooms for days down here and not quite getting adequate medical care, because what happens is when ER doctors admit someone to the hospital, they're kind of we watch them, but they're under responsibility of the hospitalist doctors, the upstairs, so to speak, doctors, and so we don't have that direct patient care with them. If something bad were to happen, the hospitalist doctors would have to, come down right away. And so ER doctors kind of have to take care of those patients, even though they're not technically ours, along with, their others. I think the patient boarding as a whole kind of contributes to a lot of the frustration, of kind of just getting these problems handled. Um, yeah, I mean, it's definitely a draining work. The other thing with emergency medicine that I realized when I started is just you're constantly going. It's shift work, which is some people like because you're not going to be on call. You're there from 9 to 6 or whatever, or 11 p.m. to 7 a.m. But when you're on, I mean, ERs are rarely not busy, and you're constantly picking up new patients and discharging patients or admitting patients. It's just this constant flux, and you rarely get downtime. I mean, ER doctors don't really get breaks. I mean, even nurses and patient techs have like an hour break for lunch, but ER doctors, if you're going to eat, you go get the food or you go heat up the food and then you bring it back and you eat at your desk.
Mhm.
And a lot of that's just there's typically not a lot of doctors on, so they don't get as much time. And if you have a patient who is otherwise not doing well, you kind of can't leave. You have to keep your eye on them. So ER doctors just you don't really get breaks. There's not a lot of downtime. It's just like a constant, always something going. Which if you have ADHD, a lot of people like that, but if you don't, then it can feel pretty taxing.
Okay. Um, I moved some stats up in the log, so we can go over those real quick before we move on. But like, I know you were dropping that stat, so I googled some. 50 to 60% of emergency medicine doctors in recent years, with the average of like I think it was 56 or above, showing burnout, quit rates. Because I like to talk about quit rates amongst PT.
Mhm.
Um, there's some studies that say about 10% of the PT work force leaves every year, which I'll get to here in a second. But for you guys, I wanted to see this is between 2013 and 2019, so before the disease that will not be named. Um, from 3.5 up to 5%, and probably even more than that after 2019, in terms of doctors leaving the field saying, I'm out, I'm done, this is too much. And then, of course, we have the suicide rate, of course, being pretty darn high for ER doctors as well. So,
Yeah, no, I mean, it's not uncommon for that, for ER doctors. I mean, there was a doctor that I'm aware of that I think she was working for 2 or 3 years after finishing residency, and she's just like, I'm done.
Mm,
Um, yeah, I mean, for this is maybe not specific to ER in general, but for physicians, I mean, most doctors have to take out a massive amount of
mm,
debt to go into medical school, to pay for medical school. And so then you have this like, I need to work, I need to pay it off. And just how compounding interest works, the more you can pay it off, the better. So even though after you grind through residency, it's still like, well, you still have this mountain of debt behind you. And so you're very much encouraged to still to work as many hours as you can.
is obviously the being paid 1/8 takes a huge role into that because that's going to be when you're working probably the most productive period in your whole life. And I don't use the word productive in terms of like mentally productive or productive for your life, but in terms of generating sheer hours and volume of work, one could argue that the residency is the most and they pay you the least, which then incentivizes you to continue to have to pay off these massive student loans with the compounding interest. So they're basically, it sounds like they're baking into the cake. Hey, I get three or 4 years of this thing accruing interest on you, or so I guess maybe 2 years for the residency, accruing interest on you before you ever even have the chance to start paying it off.
Yeah, yes. And how how the bureaucracy works is in ER medicine, there are 3-year residencies and there are 4-year residencies. And I made it an effort not to do a 4-year residency because
Mhm.
a lot of the studies, and there have been multiple on this, but they don't show any significant difference between the knowledge of a physician and board passing rates for 3-year residencies versus 4-year residencies. And so from that data, it kind of just seems like the extra year for those specific 4-year residencies isn't that useful. But despite that, I think the board that accredits ER residencies is looking to change all of them to 4 years,
Mm,
um, against most people's wishes and better judgments.
of
Um,
course.
yeah, that's just kind of how I think it is. But sorry, yeah, I lost my train of thought. I don't know if I answered the question that you had there.
Um, I think that you did, just because it was like any personal stories that tie into those sorts of numbers. So I'll move into kind of the PT side of things, which is not nearly as extensive. Um, but looking at the PT side of things, we like to like triple book. So as much as is humanly possible, we like to completely book ourselves with multiple patients at the same time, and we like to do that obviously for productivity reasons. We want to make sure that we can get paid as much as we can, but that really only works when you have private insurance because federal insurance restricts us from doing that. But what happens with PT burnout is you end up working at a place called like a PT mill, where either you are seeing like 3 patients at the same time, or you're working at a physician's own clinic, um, where every 30 minutes you're seeing a new a new post-op coming in, and you're just doing evaluations and reevaluations all day. So as a PT, you basically exist to just document numbers. Like, oh, your knee range of motion went from this to that. Your shoulder range of motion went from this. Your strength went from this to this. And I've talked about this a lot, where I chose to work on purpose at a clinic that only does one-on-one because I wanted to be invested in all my patients and I want to get them the best outcomes. So that helps prevent burnout in me. But a lot of my friends that went and took the highest paying job they could, they're like, yeah, I see like 2 patients at the same time every hour all day, not including evaluations. And so
Mhm.
that just leads to a mountain of documentation for them to do, as well as just not being invested as much. Cause it's kind of like, you know, call them Susie and Nancy. Yeah, good job, Susie. It looks like you're kind of doing the marching the way that I want you to, but Susie, you're slacking over there. That squat form is terrible. You got to step it up. And then neither of them really get the fulfillment of knowing that the PT is there helping them get better. It's just kind of like you're babysitting them to make sure they do their exercises. And I think patients pick up on that. But in those sorts of settings, we've seen like I think it's 10% of the PTs per year leave. And there was a study that I saw right here, which is crazy. Um, it says that by their 5th year, 50% of PTs will choose to leave the field. So after 5 years of practicing PT, they
Wow.
will leave. They're out. So only 50% lasts longer than their 5th year. And the things that they cited was high demands, low control over their caseload, and poor work-life balance. So what's funny to me, this is my takeaway right now. PTs were kind of like the drama queens and kings. Like we're over here like, ugh, I have to work 40 hours a week with multiple patients per hour. And then I'm out. I'm leaving this field versus like the DOs. Like, cool, bro. I just worked an 80-hour work week.
No, it's not like that. I mean, the yeah, I mean, it depends on what you do. Most after you finish residency, there's very few doctors that are working 80 hours a week.
Mhm.
And I'm sure most of them in the ER at least will hover around like 32 to 40.
Mhm.
There are some people that really grind and they work like 60 hours a week, maybe even more, but that would be very, very rare. It's the nature of the beast is just the ER shifts are very like grueling, and it's very common for people to stay like hours after their shift is technically over. Just kind of because you don't want to a lot if your patient's unstable and what everything that happened, it's hard to convey that. Like most medical errors are made when you're handing a patient off to another doctor.
Mhm.
So if possible, it's encouraged that doctors don't hand patients off when they can help it. But as a result, it's just you don't get paid for hospital systems encourage that, and they don't have to pay you for the time that you stay over. At least if you're a resident, I think there's some hospital systems that'll pay you if you're.
Let's talk about that too for a second because that ties in perfectly with what I was going to go to next, which is rate cuts, and that's something I mean, as PT, we we don't necessarily live off of government health insurance, but it's a sizable portion. Like my clinic, we are huge. We have huge military population, right? So every single time the government decides to cut the reimbursement rate for PT or skilled services, we take it right on the chin, especially because we're a one-on-one sort of clinic. So like I had pulled up here, um, basically over the last 3 years, we're looking at somewhere close to an 8% cut in terms of what they're reimbursing. Does that impact you guys the same way? Because as PT, that's like cool. Over the last 3 years, we're effectively losing almost 10% of our reimbursement rate for all federal insurances. Does that like factor into for you guys as well? Because I know the government like seems to play a pretty big role for that hospital system.
For us, to my knowledge,
Mm.
again, which may not be very extensive on the subject, it doesn't as much. It's oftentimes strange where we'll have, insurances that won't pay like reimburse tests that we order for patients. And that's kind of frustrating. So we might have to battle for our patients a little bit there. In the emergency room, I think we have, because just how it is, with the kind of life and death situations,
Yeah.
it's hard to argue against a lot of the tests we order.
Mm. Makes sense. Makes sense.
It's just, so if we're, and usually we can kind of justify that decision making in our notes that will kind of support um, the the tests and the medical care getting reimbursed. But I guess part of being in the ER too is that you're kind of like um, putting this in a nice way. I mean, you're not like the garbage people of society, but it's like a lot. It's almost like a necessary service for the public that you need emergency rooms. Everyone does, whether it's accidents or whether it's a person withdrawing from alcohol for the 10th time this year. Things can get life threatening really quickly, and so um, I think for the most part we're pretty well reimbursed, but I know that's not what my family medicine colleagues would say, and a
Okay.
lot of other doctors that practice like from outpatient clinics.
Mhm. I do wonder because this is the first time people in the podcast are probably hearing from someone that doesn't work in like one of those like I guess you would say outpatient sort of clinic roles. They're hearing more from like, oh, this is like hospital setting, and it's good that you're bringing this perspective because they may have heard from their mom or their dad, their sister, their brother that works in the hospital, like, hey, we're doing this and that. And no, this doesn't really impact us, or this legislation or this cut doesn't really bother us. Versus like their friends that are PTs that are pulling their eyebrows and eyelashes out over an 8% cut over the last 3 years. And it's the same healthcare system, it's just different settings. And it really helps give people that perspective. Um,
Oh yeah, and let me be the first to say that physical therapy is absolutely necessary, and I think it's almost a regression back to previous ways to say that like because physical therapy I would consider as, whole body care, and I've seen physical therapy change probably as many patients' lives as I have surgery, which
Mhm.
is crazy because one of them is like life threatening and carries a host of complications that can happen, and one of them is relatively easy and much better recovery rates. And so I feel like it's unfortunate that physical therapy rates are reimbursement rates are dropping, because I feel like we need more physical therapists. And I can't tell you how many how many people just with back pain that come. And I think back pain is
Yeah.
one of the most common ER complaints. And if we had more physical therapists, I think it'd be better for everyone. It would cost ERs a lot less money, which in result would cost taxpayers less money. And then it would be better for the patients because most of them, probably like 90% of them, just need a physical therapist, and that would fix their problem. And coming to the ER for back pain, there are those 10% of cases where it could be an emergency,
Mhm.
but a lot of times, we kind of slap a band-aid on it and we give them some, pain medication or in some, heating pads or some lidocaine patches, and they go home, but they'll probably be back shortly again. And I think physical therapists they're not as common. And I know patients will say, oh, I couldn't get in with this one, or my insurance doesn't cover this physical therapist, and so I can't go. And yeah, I think we're kind of inadvertently hurting ourselves as a society because we don't have more physical therapists to go to, and insurance isn't doing what it should be doing, in my opinion.
It's definitely weird being on this side of things because when I have a patient who comes in who's like, "Yeah, I just came from the ER 2 weeks ago. I thought I was having a heart attack because my shoulder hurt." And that's what that's the last thing my, fill in the blank, my grandfather said before he had a heart attack. So I had shoulder pain, so I went to the ER and they told me that I just have some arthritis. And you're like,
Right.
I could have seen you and saved you so much time, so much effort, and so much money because first of all, that's the wrong side for the heart attack. you know? So it's like it's those sorts of things as a PT that when I see it, I wish that I was there to help screen people, but I also know that not to get too tangential for a second, but I just did an entire series on how the Board of Education is looking at taking away the professionalism title for PT, basically trying to
Kind of like they did with nurses recently.
nurses, OTs, PTs, speech language pathologists, and there's a whole ruckus about that, which I'm not going to touch into that now. Shameless plug, you can go check out the previous series, everybody, if you're wondering what Andrew thought about that. But basically, what the reason why that happened though is the American Physical Therapy Association back in the 90s wanted a independently practicing physical therapist that could take people in off of the street, screen them for red flag conditions, determine if they were appropriate for physical therapy or send them back to a doctor or the hospital or wherever. And that was the dream. And the American Physical Therapy, I guess, spoiler alert, has completely failed to do that over the last 30 years. They set up an entire education system, an entire schooling system designed to get us there, but then insurances never went along with it, and neither did the government. And so the idea, though, was there should be a physical therapist in the hospital system, in the healthcare system, right alongside the DO and MD or whatever, practicing and saying, "Hey, send them to me. I'll screen them first, and I can determine if it's necessary for them to have imaging or what have you." And that was the dream that they had when they came up with it, but it's just never come to fruition. So I agree with you. I mean, I wish that there was like an emergency room physical therapist coming in there and helping screen people because Ottawa ankle rules, right? I can rule that out in 5 minutes as a PT and say, "Oh God, yeah, your ankle's broken. You need to get over there and get an ER." Or no, no, you barely tweaked your ankle. It looks like it's ligamentous. It's your, calcaneofibular ligament. You're fine. Let's get you a cam boot and some ice. All right, you're going to be okay. Just being able to do those two things in the ER setting, I feel would save a lot of time. Um, Go ahead.
Yeah, that would be. I mean, I think we get a lot of patients that come from primary care offices,
Mhm.
um, and yeah, I mean, I think if everyone, like, if you had a patient that was coming to you and they're like 'cause a lot of patients put health off. They kind of go to stuff when they feel like it's unavoidable. So I feel like it's probably not uncommon for you guys to have a patient that comes in and like, oh, I've been having this chest pain for 3 days. But I didn't want to go to the doctor, and I knew I was, seeing a PT. I think it'd be useful. I mean, for everyone, for getting better at like kind of medical screening exams, as they
Yeah.
refer to. Um, definitely would help. Definitely couldn't hurt.
The VA and the Walter Reed when I was there as a student, yeah, it was like a 1 in 3. Someone's gonna walk in, their blood pressure is gonna be 220 over 105, and they're gonna say, "My chest hurts." And you're like, "Let's just have you sit down and wheel you right on over to the ER, sir." Like,
Mhm.
and they'd be like, "Oh, well, I didn't take my blood pressure medication for the last 3 days." You're like, "I know." We all know. We all know. But no, you are not appropriate for PT at this time. And they'd be super confused. But just being able to be there to screen who's appropriate and who's not, I feel like, and who's appropriate for imaging and not. There was some study they did where they said PT would save, I forget how much money it was. I'll have to look it up after this. But it was the amount of money we would save in imaging for X-ray and MRI alone, in theory, being plugged into the system that way, was ridiculous. Which is why I didn't believe it at the time, because I'm like, that's just like shamelessly lying to the healthcare system. But now practicing for a year, I'm like, oh no, it's true. The amount of people that come in and say, I think I broke, fill in the blank. And I'm like, no, no, you did not break that. You're fine.
Yeah, I think it's especially because MRI is you really like there's to rule out it's easy to rule out a fracture, a broken bone, because x-rays can do that.
Yes.
And even more specific CT scans can do that, but it's very hard to rule out soft tissue injuries like ligamentous injuries, tendon injuries. You need an MRI, and even then it's not the best. So I feel like that is an area where clinical gestalt, I think, as they say, or clinical knowledge, clinical experience.
Sir, keep it to a sixth grade level for the podcast.
It's just a fancy word that a lot of old doctors will use to sound smart.
I mean, we use our special testing, which you're familiar with, a lot of the special tests where it's like, oh, okay, this is definitely something probably going on with the tendon or ligament. Maybe an MRI would be useful. I mean, the amount of times I can probably count on both my hands the amount of times I've actually referred somebody out and said, hey, you're coming in after working with each other for like four weeks or so here. You're definitely presenting with something more ligamentous or capsular. I think an MRI is warranted, which is nice because that means the patients that I'm getting have been so thoroughly vetted, I've been pampered. But there's been a few of those where I'm like, because they're like, I can't get an MRI until you write a letter to my doctor saying I need one, so you should write one for me. I'm like, no, I'm not doing that till I'm guaranteed that I know you need one. And there's only been one extreme case in a year where a dude actually had like a near full thickness tear of his supraspinatus that I knew. And that was me arguing, not with one doctor, but with an entire system saying, hey, you should have an MRI because it's been like 12 weeks and he still can't lift his arm up above 90 degrees. Something's going on here. And they pushed back until he finally got an MRI. And they're like, oh, yeah, it's a near full thickness tear. I'm like, I know. But
Right. No, that happens enough. And honestly, clinical, what you do can save people a lot of money and save the healthcare system as a whole a lot of money, because MRIs aren't, they're not cheap. But yeah, I mean, there was a guy, I think it was at like it was like this event I was at not long ago, and there are these two college age kids that were arm wrestling.
oh no, I don't like where this is going.
And nothing better to do. So one of my friends FaceTimed me, and I just left, and they were like, "Hey, can you come back? This happened." And they kind of told me the whole thing. And at first, I thought I was like, it sounded like they were describing a shoulder dislocation to me. So, and I just reduced one that was like earlier in the week. But then when I went there, yeah, he described it, and it was full on arm wrestling, and then he heard a pop, and then he had a little bit of retraction. I think it was a biceps tendon partial tear. And so I was able to kind of like help guide him. We got a sling for him, and sent him on his way to ortho. But I think you guys probably deal with that a lot, where you're kind of determining or helping determine at the very least if MRIs are warranted. It's such an expensive test, sadly. That I mean, it'd be nice if we can give everybody MRIs, and we'd probably in some cases be a healthier population, but they're so dang expensive that if you can diagnose with some pretty good accuracy those types of injuries, then you can save kind of everyone hassle and money, which is awesome.
Yeah. And my favorite is when I have a patient walk in and says, "I need a full body MRI." I'm like, that doesn't exist."
Yeah, one time, one time when I think it was an intern, and I had this girl come in. It's like when they use the medical buzzwords. And she came in and I've never heard someone else say this like before then or after then, but she told me that she had saddle anesthesia. And I was like, what? I was like, "What's saddle anesthesia?" I was like, you don't, what does that even mean? And she was like, just kind of numb, I guess, in this area. But usually, when you have a syndrome like called Aquina syndrome or
Yeah, yeah,
clinician
yeah.
which are emergencies which need urgent MRIs, your testing or the patient is kind of like, yeah, I guess I haven't felt as much in my groin,
Mhm.
um, but this patient really wanted an MRI, and so she came in with the buzzword requesting a specific image.
Sneaky. So, those people exist. They watch House
Oh
MD,
yeah,
and they walk in, they're like, "Oh, here's exactly what I have. I have the rare blah blah blah." And you're like, "Nah, I don't think so." But
oh yeah. It's bad when you have a smart hypochondriac, or it's illness anxiety disorder now.
oh, okay,
Um,
let's make sure we don't call them hypochondriacs. Uh,
Hyperchondriasis, yeah.
let's segue. Let's land the plane before we have fun all evening. Um, let's land the plane on cash-based solution. We'll kind of jump over the other section that we had there because we kind of hit that nail on the head. So with everything that we kind of set in mind, one of the things that I've been researching a little bit, I know I've talked to you a little bit,
Mhm.
is the cash-based way to get out of burnout and to still be able to provide uh, not just like good care, but better than average, high quality care. The sort of care that's like not just, hey, this person's getting better, but it's also the kind that you signed up for when you thought about being a doctor or a physical therapist. Is this is what I wanted to do. This is how I wanted to practice. I wanted to be invested one on one. I wanted to help people get better. So I'll lead off on that real quick. Just because I've been researching a lot. So like one of the things I think of with that is cash-based PT. Really, the only drawback that we have is that you have to do documentation, and the documentation still has to largely be compliant with insurance standards, even though you're not submitting to insurance, but you're still practicing. So you still have to do a lot of that. So you have to figure out how to do documentation on your own. But the other thing that you can do is you can kind of you can change the system. Instead of doing a 30-minute or a 45-minute treatment session, you can go for an hour or longer with the patient. And scheduling is a lot more flexible, which means you're there as long as it kind of takes to help them get better, as long as it doesn't impinge or limit the next person. And you can do as many visits as you want. You're not like stuck with a plan of care where for PT at least, we're kind of stuck like, hey, I can only see you 1 to 2 to 3 times a week. That's all that insurance will reimburse for, even though maybe you could handle more than one time a week, for example. You can only really afford once a week or once every other week in some cases. With cash base, it's more of like, nope, I can see you like every day this week. We can kind of go through your workout program and tweak everything to kind of help you relieve this pain. And I can see you again in a month if we need to. And we can see how that goes. It's a lot more flexible. It's a lot more one on one and actually kind of meeting the patient where they're at and getting them whatever it is that they're looking for. If they're looking for getting back to the gym or they want to get better at, um, in some cases, getting better at their running, right? Okay, I'm going to take a look at your run form. I'm going to change your PT, your exercise program to try to shape that. Or, hey, your post rotator cuff, let's really go heavy here early in the beginning, make sure your range of motion comes back normal, and then we can really focus on strength later. Um, the whole cash-based system just allows for you to be way more adaptive, way more flexible, and have a lot more control of your schedule. And use like one of the things that they keep harping on that when I read the literature is it really lets you be free to use your clinical judgment to treat the patient instead of being bound by insurance or by trying to just meet some certain productivity quota that the clinic has given you, where you must see 52 patients a week or whatever it is. You can instead be like, nah, I'm only going to see X amount, but I'm going to definitely invest in them. So I didn't know for you guys if you made the switch from ER to cash based, preventative care or urgent care, things like that, how that would look for you guys. Because for PTs, it sounds like the dream. It's just having enough patients to make it work feasibly.
Right. Yeah. I've heard a lot of doctors do this, and the ones that do are very happy. And maybe that's the survivorship bias of you only hear from the people that have a successful business and have a good model. And the ones that fail just go right back into the system and don't talk much about it. But from the ones I've heard, the success stories, it's very beneficial and patients love it. Um, the cost varies. So a lot of people, obviously, in the United States, they have uh, the your insurance is tied to your career,
Hmm.
or you're on Medicaid. You get it from kind of the government subsidy, and so in those populations, people often don't want to spend extra money to get a doctor, say for $100 a month. And I think there's just like there's not a lot of man. I mean, not to roast doctors here, but doctors are very they're very structured people. Like they're not very creative or independent. So doctors are hard workers. I think these are all generalizations. They follow if someone tells them to do something and they give them a structured set up like way to do it. Doctors are good at doing that, but they're not very good with autonomy or creative solutions. So like the whole of creating your own business, creating your own structure, setting your price point, setting things that you want, things you don't want. Because some doctors will have cash based models where it's an annual fee of $2,200, or they'll break that down to months. Monthly fee of $100, and then they'll kind of have access to you, whether it's your email or your phone number, and then you can have monthly or semi-annual or annual visits with this doctor, and as a result you get your medical care that way, and they manage your medications, they do all primary care. Instead of going to an urgent care, you can just schedule a quick urgent care visit with your primary doctor that you're paying an annual subscription for. And there's different models that kind of break down, okay, this, if you pay 150 a month, you get this many visits, or you get access to our PT team, or you get access to I don't know,
Hmm.
lifestyle modification stuff, Botox, your interview, your IV fluids, and you can get, potassium, banana bags, and all that, lifestyle modification medicine stuff. Um, for that, I've heard a lot of people that love it. Luckily, most of my practices in the ER, and so I've got plenty of friends that are family practice doctors, and they cannot stand that they have less than 10 minutes for each patient, and they kind
Hmm.
of have to whiz through people. So there is a lot of benefit to having 30 minutes to talk to a patient, and it's better for you, it's better for the patient. Um, but kind of like we were talking about earlier, where hospitals and clinics, these medical groups are run by businessmen and businesswomen, and their whole goal is bottom line. It's how do we squeeze every penny out of the system? And if our doctors are going at, 6 minutes per patient, sure, they're more likely to miss things, and it's maybe not as good for the patient, but the offset of seeing 5 times as many patients makes up for the few errors that they'll make over the course of months. So that if there's a lawsuit, it's like one in 10 of those might turn to a lawsuit, then their cost benefit analysis is it's worth it. um, so it's not good for the patient, it's not good for the doctors, but it generates more revenue. And I think, I'm no, I think that's why it is the way it is. Follow the money, right?
Yeah. It it's frustrating when, like, working in a company that's beholden to the stockholders and generating profit at all cost is just it's soul sucking for a reason, right? It's worship of money is what it really comes down to, is worship the bottom line. Graft must go up, stonk must go up. If stonk does not go up, we have a problem. And I think that's what people don't understand about the healthcare system at large. when they first enter it. They just think it's an entire system that's leveraged against them specifically, and they don't realize that it's the healthcare professionals and everybody who's practicing as well, that they're equally, if not more so, yoked into this system that's forcing them to behave this way. It's not that they're choosing to behave this way. It's the system is structured this way. And that's one of the reasons why I launched the podcast. Because I wanted to inform people like, hey, this is how it's structured. And if you really do want to make it, if you really want to make a change, if you really want to get better care, look for the small 1 or 2 man operations out there, 1 or 2 woman
Oh yeah.
operations out there, and seek them out. And even if they have a 3 month, 6 month waiting list, they're worth it. And they're worth it because they're going to be the guy or the gal that sits down with you for 30 minutes and says, well, let's do a complete review of your medical history and the medications that you're taking, because that's what's important. And I need to know who you are as a human being and what you do. And from that consultation, we can move into, is PT appropriate for you or not? Do I think you should do it? Is imaging really necessary? I don't know. Go over here and talk to, Andrew, who's sitting next door in the PT clinic. Or, you know what? I think you benefit more from a nutritional consultation, because it sounds like a lot of your issues could be gastrointestinal, more due to this. And that really allows you to sit down, use your clinical judgment, to analyze the person as they are, as a person. Um, that's one of the reasons why I started the podcast. I know it's named the world's okayest physical therapist podcast. And good job not laughing at that in the beginning. But it's kind of evolved more into, how does one navigate the healthcare system? Um,
Oh yeah. And there's, I mean, like if a doctor has more time to take care of a patient, they're going to get significantly better care. I mean, it's the equivalent to like if you give, a painter, 6 hours to work on one painting versus, you know, 5 hours to work on 10 paintings, like just the quality of care or the quality of the painting is going to get better. It's the same way with doctors. And I assume in your case, like physical therapists, where it's just going to be better quality. I mean, if you have a doctor that's taking care of their son or daughter, they're going to do a heck of a lot better than, the one or two patients they see in a given week. It's just the more time you get, the more you focus on that. And a lot of doctors like this cash-based model just because they don't have insurance premiums to worry about. They don't. It's them and it's medicine and it's the patient, and so they don't have it. There's no middleman for them to have to deal with or negotiate with or not to reimburse their care. I think they
Mhm,
love it.
mhm. But I think one of the misconceptions too is a lot of people think, because they're going to be paying out of pocket for cash base, they think that it ends up being more than it would be with insurance. And I think a lot of times, just to your point, sitting down for 1 hour or 1/2 hour with a doctor can be expensive, but how many thousands of dollars are you going to save later if you sit down, and you head things off preventively in the beginning, just like you're saying. And to tie it in a bow with the previous thing, the burnout. I mean, the fact is, you're going to know that patient. You're going to be emotionally invested. You're going to care, and you're going to be happy. In a perfect world, you're going to be happy when they walk through the door to talk to you, um, telling you about their progress, and you're invested in them, and they're invested in you. And maybe you get to go play a round of golf afterward. If things are going great. And
Mhm.
it's that knowing that you're having an impact on the community, on people that are living long, happy, healthy lives, and living up to their potential. Because I think that's one thing that's so soul sucking for me, at least in the clinic. I can imagine the ER. You just see a bunch of human potential going absolutely nowhere because these people are just disillusioned. No one's taking the time to explain to them exactly what's going on in terms they can understand. And they are, like you said, it's kind of shoved to the side in a hallway, said, I guess you're going to stay here until a bed opens up. Or in the PT, it's like, yeah, well, your other PTs gave up on you because when they were seeing 2 people at the same time, you were the one that was the squeaky wheel that they couldn't figure out how to get better, and it took too much analysis and analytics for them to figure it out. So they said, "I don't know, you're not getting better. Good luck." And then they end up to me where they said, "You're the third PT clinic I've been to. You're the first one that's going to pay attention to me one on one," which I think is sad. But um, all that to say, I think that plays with helping prevent burnout and also making your patients healthier. But do you have any closing final thoughts or remarks, that do not go along the lines of "down with the healthcare system, lead a revolution," sir?
No, I mean to figure out if you're trying to guess, the way out of it. It's hard to find a silver bullet that's gonna fix all the maladies. I think when you're a kid, you think that you can change things, and that the system's broken and it needs fixing, but the system has been broken for a long time,
Mm,
and the system is the way that it's designed to be the way that it is. So I think acknowledging that is important. And I think if you're a patient and you may want to consider some of these other models. Obviously, like you ultimately decide as the consumer, um, you know, based on you vote with your dollar. If and I don't have this practice, but if you're like, you know what, I'm gonna take out my health insurance or do a minimal cost plan with my work, and find one of these doctors that is cash based model, you can kind of get that time put you can get more of a connected relationship, and overall hopefully have better care. That is outpatient, obviously, like that's
mm,
to do that in a hospital setting. Right now we don't have any type of framework for that. So obviously, if you're very, very sick, that you're still going to have ERs, you're still going to have hospitals. But I've heard enough people complain about, I have to wait 10 months to see my doctor, your primary doctor. And a lot of those things, you might have a serious medical complaint. I mean, I get people all the time where, I was looking at this rash, or, I was having this pain, but I couldn't get in to see my doctor in, 8 months.
mm,
And by then, whatever you had, whether it's a disease process or it's, cancer in
mhm,
the worst, could have otherwise been prevented if you'd just seen a doctor that week. And so a lot of these cash-based models have success in that sense if they can see patients faster, and then the doctor has, you have the doctor's undivided attention.
mhm.
And I imagine for PT, it's probably similar. I mean, if you guys are a mill and you're just trying to grind out as many patients as you can, ultimately, their pain might not get fixed, their disabilities might not be corrected.
It it's very similar. I mean, the amount of I call them secondhand patients because they've gone through one PT clinic and then they didn't fix them. And that's the words they use. And I tell them when they sit down with me, I'm not going to fix you, but I'm going to help you get better. The how much better is going to really come down to just a whole bunch of things. But what's crazy to me is seeing the people that are walking around that were discharged like post ACL reconstruction, and their quad is at 25% strength, the other quad. And you're like, how did you make it out of PT? That's like, well, I ran out of visits. Like, did they
Mhm.
give you any alternate? No, they just went through 3 visits per week for the first, and you're like, "Oh, so they just burned through your visits without thinking about it." Or people that are post hip or post knee that, like, still have gait abnormalities.
Mhm.
Um, yeah, it just it blows my mind, but I think you nailed it on the head there, and, like, in that sort of setting, it makes perfect sense, but, like, PT in a hospital setting, yeah, I have no idea how you would ever do cash based there. I think there's a time and place for both, to your point. 'Cause if I just had cardiac surgery, I don't wanna do cash-based cardio pulls, you know?
Oh, especially with the price. I mean, it's the whole, you know, when you look at things in the hospital, everything costs so much more money. And it's the same, like anytime insurances are involved, the person selling the service that the insurance is buying can set an insanely high price. If you ever look at like auto body repair shops, like replacing a bumper is $4,000, and the labor takes less than an hour, and the product itself is $500. But when you can charge whatever price you want, insurance will generally pay it. There's not a lot of competition, and it doesn't drive down costs. And it's the same with healthcare insurance. Like, I mean, a central line kit is over $1,000. I think it's like $2,000. And there's things that are like little cautery things, or even like a staple gun, that's insanely overpriced, and insurance companies don't negotiate well for the people that pay for their insurance, you or me. And so they can charge a lot of money. So I think with the cash based models, they really, it's more capitalism in its best sense of competition driving down costs, and charging the consumer the lowest possible amount, which is nice.
It's capitalism working the way it's supposed to instead of corporatism, one could say.
Yes, yes.
Um, well, this has been I will call this episode "Watch a DO Flex on the PT." The PT thinks he has problems, but the DO puts him in his place.
Oh, no, sorry. I'm just complaining. That's really all it is. I appreciate you listening to my complaints here.
Well, thank you for
Talk to
joining me tonight. I have an entire series fleshed out, so hopefully in the future we can make some time. We can keep going down this rhythm because I think it's something that's worth exploring. I think people are going to find your insight honestly invaluable, because they're used to hearing a PT just complain. They don't get to hear a DO and a PT complain.
I'm sure that's what they're looking forward to.
But thank you for joining me. Now, everybody, stay healthy, stay fit, stay awesome, and stay tuned until the next episode where we'll see if Dr. L comes back. We'll see if you guys behave. He'll come back.